Hello, everyone, and welcome back to The Wrap, brought to you by Michigan Medicine Headlines. I'm Dan Ellman with the Department of Communication. Today, we're going to talk about an important program that is helping to save lives at Michigan Medicine. Two members of the liver transplant program are here to discuss their work and how it is helping patients get the critical care they need. Now, before we begin that conversation, be sure you go back and get caught up on all the episodes of The Wrap you may have missed. You can find the shows on your favorite podcast hosting platform or on the Michigan Medicine YouTube channel. With that, let's bring in Dr. Sasha Shingina and Dr. Seth Waits. First, can the two of you introduce yourselves and explain your roles in the liver transplant program and your roles here at Michigan Medicine?
Thank you so much for the introduction, and thank you for having us. As you mentioned, my name is Alexandra Shingina. I'm an associate professor of medicine here. I'm one of the transplant hepatologists, and I stepped into the role of the medical director of a liver transplant program as of last summer. Happy to be here.
My name is Seth Waits, and I'm an associate professor and the surgical head of the liver transplant program here at Michigan. Excited to be here with you today, Daniel.
Outstanding. Well, I'm excited to have both of you here. Now, I know your team has had unprecedented success lately. What does that success look like, and what would you say has contributed to it?
You know, I think it's probably a little bit of a Michigan cliche, but I think the success of the transplant program can be directly attributed to something Bo Schembechler used to say, and that is the team, the team, the team. And no, I think medical service at the university is more of a team than the transplant team. And that's because it's so multidisciplinary. We have amazing teams of hepatologists who are world renowned for their contributions to the field, transplant surgeons, nurses, social workers, psychologists, coordinators, and all working collaboratively to make sure that we provide the best comprehensive care for our patients. But I think lately, the most exciting thing in transplantation has been the explosion of innovative technology in the field that has really pushed liver transplant forward. And hopefully we'll get a little chance to talk about some of those innovations later on in the podcast.
And I think it also has to do with the aggressiveness of the surgical team here at the University of Michigan, where our surgical colleagues are willing to go out far and go out in the middle of the night and look at the organs that, far away from Ann Arbor that maybe were not on their radar before or other programs, and as well as very meticulous daily wait list review, where we look at all of our patients who are waiting for the liver and we try to make the decisions based on the needs of each listed patient. We also have a robust protocol for early transplant for acute alcohol-related hepatitis, which is a condition that leads to severe inflammation of the liver in the context of significant recent alcohol use. And these patients are usually admitted to the hospital really sick, with their last alcohol drink being right before they got into the hospital, and they require transplant urgently during the same hospitalization. We also have developed and maintained protocols for transplanting people with liver cancers, bile duct cancers, and colorectal cancer metastases for at least the last 10 years. And this was much earlier before it was embraced by the transplant community. And now these patients actually get a special priority on the transplant list. We have a thriving living donor program that provides opportunity for people to help their loved ones who are in need of organ transplant. And we are also accepting anonymous donor. We extensively use hepatitis C positive organs with excellent cure rates post-transplant. And then we do have an active participation in clinical research that led to pioneering studies that enhance understanding and treatment of liver disease. And we're very happy to see a lot of those physicians who are leading those studies as a part of our transplant team.
I mean, that's amazing. You guys have covered a lot of ground in a short period of time. If you could, and maybe this is an impossible question, if you could sort of break it down, like what would you say is the biggest strength of your program?
You know, I think the biggest strength is that we don't take days off in the liver transplant program, and leadership does not take days off in giving us what we need to transplant our patients. The hepatologists do not take a day off getting patients listed. The nurses do not take a day off of making sure everything is ready for the patient when they get here. The surgeons don't take days off on the weekends and holidays. We're looking at every offer that comes out for our patients. I think that is the reason why we don't miss opportunities for our patients, because we just don't take days off here at Michigan.
I think that's amazing. And it's really a great recognition for the work that is done in your program and obviously across the organization. I think the same can be said for so many of our incredible employees here. So let's talk a little bit now from a patient perspective or a more medical perspective. Can you just explain to our listeners how a patient's eligibility is determined for a liver transplant?
Absolutely. So it starts with a patient being referred to our multidisciplinary liver transplant clinic. These are clinics that are available every day of the week, so we have great access for our patients. And once the patients arrive, they're seen by a team, by transplant hepatologist, transplant surgeon, social worker, and transplant coordinator who will guide them through the transplant evaluation process. During the same day, we do preliminary blood work, some preliminary testing like chest x-rays and ECGs. And then we discuss their candidacy at our selection committee that takes place on a weekly basis. In broad terms, the eligibility for liver transplant is determined through a thorough evaluation process that includes going over the patient's medical history, the severity of liver disease, overall health, any comorbid conditions. We do a thorough psychosocial assessment where we evaluate patients' mental and emotional readiness for transplant, including support systems in place and adherence to medical treatment. And then we calculate the MELD score. So MELD score, I'll talk a little bit about that. It stands for Model for End-Stage Liver Disease, MELD, and it's a score that's calculated based on the blood work of how well the liver and kidneys are working. And it's a numeric scale that we use to prioritize people on the transplant list. So people who are waiting for a transplant right now are listed according to their MELD score. People with a high MELD scores are going to be on the top. They are the ones who are going to get the next liver, and then the MELD score comes down. The MELD score, traditionally, people with MELD scores below 20 had very low access to organs, meaning that they were unlikely to get transplanted. However, at the University of Michigan, we have been transplanted at much lower MELD scores. And maybe I'll ask Seth to comment a little bit about why that is.
I always think the MELD score is just one metric of how sick a patient is and how the liver disease affects their life. If they're traveling to the hospital, 2 times a week to have fluid drained off of their abdomen, or if they're, having some confusion related to their liver disease, sometimes that's not reflected in the score that they print out for their MELD score. And so recognizing patients that have special needs for liver transplant that make them sicker than would indicate means that as a transplant center, we need to work as hard to get every single patient transplanted, because that score doesn't really tell the true story all the time.
Well, and I think that sort of points to a holistic approach, right, to a patient, right? So you're looking at all aspects of their life and how the disease that they may have or the ailments that they may have are affecting them.
I think that's totally true, Dan. It means not just looking at the labs when the patient, but it's really hearing their story, listening to the reasons why they're not able to live that life that they want to live, and then taking that into account when we think about what organs might be a good fit.
So another thing that maybe our listeners may know about is what's called the transmedic pump. Can you tell us what that is and which types of patients are using it and why?
That's a great question. I alluded to it a little earlier when we talked about innovative technology. But over the past 5 years or so, the transplant community has had this incredible technological advance that's called the TransMedics OCS device, the Organ Care System device. And essentially what this device is, it allows us to take a liver out of a donor, put it on the pump oxygenated blood through the liver, and allow it to live outside the donor or recipient's body for a period of time to assess whether that liver is going to do well when it goes into the recipient, but also recondition it a bit so that when it does get transplanted, it provides a much smoother course for the recipient. And that has allowed us to pursue donors that we would have never dreamed of 5 years ago, meaning donors that are maybe older, or the liver, has some infiltrative fat in it or something that would have sort of scared us away a few years ago. It allows us to take that liver, optimize the liver, make sure it's going to work when it goes into the recipient. And in a lot of cases, this allows us to find and my partners always make fun of me for this, but to find diamonds in the rough. So send our teams out to look at livers that we would, otherwise maybe not consider, for the one opportunity in five that it might be a really beautiful liver and give someone another opportunity at the gift of life. One thing I wanted to mention too is that when you do transplant these livers, it uses a lot less resources that ultimately, the hospital and the patient can benefit from, meaning there's less kidney injury afterwards needing dialysis. There's less blood product utilization. And in a time when we're resource constrained from a blood product standpoint across the United States, that's really valuable as well. And then patients are getting out of the ICU and out of the hospital faster than we ever have here at Michigan. And I think that just is an incredible advancement for our patients.
Yeah, that's amazing. Can we talk about living donors? I know that Michigan Medicine has a living donor liver transplant program. What does that entail, and how can somebody be a living donor? Can you explain that a little bit?
Yes. So in 2017, we really started in earnest in pushing forward the living donor program here at Michigan. And we've done 36 donors since that time. In broad strokes, a living liver donor is someone who's interested in donating half of their liver, or in some cases less, to an adult or a child in order to provide them with the opportunity to have a liver transplant. And it's particularly valuable in those cases we talked about earlier, where someone's MELD score might not be high enough to have an opportunity to get a whole liver from a deceased donor, but they really have a specific need for transplant. The operation itself is very similar. You take out the entire diseased liver from the recipient, and you put that piece of liver in place of it, where over the course of 6 to 8 weeks afterwards, it grows to be nearly normal size. It's really an incredible opportunity to be a part of living donation.
And what is sort of then the follow-up like for somebody who is the living donor?
Yeah, the living donor, it's a major operation. And Sasha, you probably give a great answer for this.
Absolutely. So we do follow our living donors for a total of 2 years. There is a predetermined frequency at which they should be assessed by a medical healthcare professional and get blood work to make sure that they're doing well. And so far in the medical community, we do not know of any long-term adverse effects on the patient's life of people who decided to become a living donors. They do not seem to be at increased risk of liver disease or cirrhosis or kidney disease. Women who donate their livers go on to have healthy pregnancies. So overall, whether there are small risks that are associated with this procedure of donation are confined to the immediate surgery rather than long-term.
Yeah, it would just be the same risks as any major surgery would, right? I mean,
correct.
That's really amazing. And there's innovation, right? Like, it's just incredible. It's using technology, but it's also the innovation, like the amazing what the human body can do and sort of like regenerating it, as you mentioned, Dr. Waits. I think that's really incredible. All right, let's talk about go back to the patients a little bit again. And I know that you mentioned this a little bit ago, but let's dive a little bit deeper. Can patients who are diagnosed with liver cancer be eligible for a transplant?
That's a great question. Yes, absolutely. Patients with liver cancers, bile duct cancers may be eligible for liver transplant, typically based on a specific criteria. So there's something that's called Milan criteria for liver cancer, which includes tumor size, number of tumors, and the absence of vascular invasion. However, there has been recently some changes to the criteria that qualifies person for a liver transplant from what's called the UNOS, which is the governing body allocation system in the United States. And it really has expanded the indications for what we call transplant oncology for patients with liver disease to include not only more significant liver cancers, but also bile duct cancers that were really previously were considered a contraindication to liver transplant, as well as colon cancer that has metastasized to the liver. And it also lets these patients have access to liver transplant in the context of not only living donation, but actually prioritizing them on the wait list. Now, as you can imagine, all of these have specific treatment protocols that have been developed at the University of Michigan over 10 years ago. And we have a well-established multidisciplinary tumor clinic that consists of surgeons, hepatologists, oncologists that help us take care of these very complex patients pre-transplant.
And then what is the ALD program? Can you tell us a little bit about what that is?
Seth, do you want to talk a little bit about the background on this program?
Oh, yeah, gosh, I would love to. I think it feels like an emotional topic because I remember back during the pandemic when we saw an uptick in people who were admitted with alcohol-related hepatitis. And there were so many ICU nurses and patient families that would come to us and with stories of young people dying of liver disease. And it was sort of a sad, really frustrating time. And we didn't have a lot of infrastructure in place to make sure we're taking care of these patients in the best way possible and offer them, a second chance related to their liver disease. And there was some groundbreaking research at Michigan looking at rates of alcohol-related hepatitis across the United States. And it was clear that there was a growing population of patients who needed care for their liver disease and many who needed liver transplants that we were, as a transplant community in the United States, I think, underserving. And that was some of the impetus for the growth of our program related to providing transplant care.
And currently, it exists as a multidisciplinary program where we have a transplant hepatologist and addiction-trained transplant psychiatrist evaluating patients for alcohol liver disease clinic that kind of creates a comprehensive assessment that assesses not only their need for alcohol cessation or pharmacotherapy that we can offer, but also management of their liver disease at the same time. And as we always say, the goal of the alcohol liver disease program is for patients not to require a liver transplant. However, if patients do require a liver transplant, it's very helpful to have them already been assessed both by transplant psychiatry and transplant hepatology during their evaluation. And the development of alcohol-related liver disease program is largely due to Michigan Medicine leadership commitment to providing resources needed to grow the program for patients who are struggling with alcohol addiction and with liver disease. And we are definitely very thankful for that.
Yeah, that's great. All right, I have a multi-part question here, so bear with me. So can you just explain sort of what a transplant surgery sort of entails, what that looks like, what advice you might have for patients who are either hoping to or about to undergo such a surgery, and then even further, what advice do you have for your colleagues who might be treating patients who are getting ready for a transplant surgery or who may have just undergone one and now are, getting follow-up care?
Well, the liver transplant itself hasn't changed a ton since we first started doing liver transplants many, many years ago, almost 50 years ago. But the steps are, in general, we work very closely hand in hand with our anesthesia colleagues. And we have a specific group of anesthesiologists who have trained in taking care of liver transplant patients and are exceptionally important in not only the process of the liver transplant itself, but they know the patients way before in the preparation process. When you go back to the operating room, they spend about an hour preparing the patient, putting in IVs and lines so that we can make sure we're monitoring their hemodynamics throughout the transplant. And then an incision is made under the patient's right rib cage. We take out their entire liver and essentially plug the new liver into the same vascular connections that the old one came out. And if you can imagine, back in the day, it took about 18 hours to get through that process. And now it's routinely from incision to closure in the 4 to 5 to 6 hour range. And some of that is the new liver pumps, which prepare the liver in a way that it works right away when you sew it in. And some is just advancements in surgical technique and technology that allows that to move through. Once the liver's in, it warms up for a while. We make sure that it's doing all the things it needs to do. We hook up the new bile duct, which drains bile from the new liver into the patient's bile duct so that that can drain into the intestine and help with absorption. And then the patient's closed up with just skin glue on the outside. The vast majority don't even require a drain. And about 50% of our patients are able to be extubated or the breathing tube removed before they even leave the operating room, which is a drastic change from what it used to be. There's about a day to a day and a half in the ICU, often just to make sure that we're paying really close attention to the liver function in the first 24 to 48 hours. And then our average length of stay is about 7 days afterwards. And many patients go home in 4 to 5 days, depending on how robust they are coming into it. I was going to say, I'm going to kick it to Sasha for the advice piece, but I think the one bit of advice that I tell every patient is that the more prepared you are going into it, the better we'll come out the other end and the faster all of those steps will move along. So I ask them every day, use your mind and use your muscles and be prepared because we may call you tomorrow for that liver transplant and you want to be as ready as you can.
Yeah, a lot of times I have conversations with patients suffering from end-stage liver disease. And as all of these things are happening, a lot of things are out of their control. The severity of their liver disease, how fast we're able to find organs for them. But one thing that I always say that is within their control is diet and exercise. The stronger you're going into the transplant, the less complications you're going to have and the better outcome you will have. So I really encourage people to take control of high protein diet, at least 30 minutes of exercise per day to try to maintain that muscle mass, because unfortunately in patients specifically with end-stage liver disease, the body starts breaking down muscle and people can become even too weak for transplant. Another thing that I would mention is that we do have a dedicated monthly liver transplant support group that is led by our incredible social worker, Megan Wind, where patients who are listed for transplant and those who have already undergone liver transplant have a forum to discuss their expectations and experiences post-transplant and to share them with patients who are going in. And every time we go to those meetings, and usually me or Seth try to join so that we can also provide a little bit of medical background for patients' questions, it is just so inspirational to see patients who have done well after transplant giving advice and relaying all of that experience to our listed patients. I would encourage everybody to log in, even if you're not related to transplant. It's just a lot of positive vibes.
It is a heartwarming experience to see patients regain all of those parts of their life that they enjoy so much. It's an incredible experience. The last thing I was going to say is that we've had to really retrain all of us to think about patients with low MELD scores as potentially getting a liver transplant really fast, because historically, unless your MELD score was pretty high, there wasn't going to be a lot of opportunity to get a transplant. But we tell every patient, and I truly spend a lot of time with every patient saying, when we list you, we may call you tomorrow. So you need to be ready. Have your cell phone turned on and your family members have their cell phone turned on because we really truly hope to call you tomorrow to come in for a liver transplant.
Yeah. That's amazing. I just really want to touch on what you just said, Seth, about how it's emotional. And I wanted to ask both of you what it's like to sort of see patients before and see patients after, and how their life has changed based on a surgery that you either performed or helped them get.
Yeah, I always say that my post-transplant clinic is the highlight of my week. A lot of times when we see patients after liver transplant, it's hard to even recognize them because of even how much they have changed, how their appearance have changed. And when patients share with us all the experiences that they get to have, that they were not sure if they would be possible, graduations of grandchildren, weddings, just these life events that they get to experience because of because of the gift of life. It's really inspiring.
All right, let's look ahead. What are you most excited about, or what are some of the goals that your program has in the months and years ahead?
That's a great question. Well, as you may know, that University of Michigan set a state record for the number of liver transplant performed by any program in 2024. We have finished the year with 131 liver transplant, which we are very, very proud of. And this is an amazing accomplishment, and it's very gratifying to the transplant team, because if you think of it, it's not just numbers. This is, going from a volume of 70 to 80 livers per year to doing 130 transplants per year. This is 40 or 50 people, mothers, fathers, who get to celebrate another July 4th, another Independence Day, that we were able to give the gift of life. And we would love to keep building on this success and offer our services and expertise to our patients. We are trying to expand our program so we can bring this experience to more patients. In this year, this spring, we have launched a new liver transplant outreach clinic, which takes place in Grand Rapids. And we're really aiming at expanding access to care and establishing this clinic in the West Michigan to better serve patients in that area. This summer, we are hoping to launch a Traverse City outreach clinic because, as you know, a lot of patients that we take care of have difficulty with transplantation services from the northwest of the state. So we're really hoping to bring our services to them. And I'm very excited for the next couple of years at University of Michigan. I think it's going to be a very exciting time.
Well, I'm excited to hear about it, and hopefully you two can come back and share all of the incredible milestones that you reached. Thank you so much, Dr. Shingina and Dr. Waits, for sharing your insight into your incredible program. If you want to learn more about the liver transplant program at Michigan Medicine, go to mmheadlines.org. That's mmheadlines.org. All right, it's time for the lightning round when we ask one of our guests 4 quick-fire questions. Dr. Waits, you lost in tic-tac-toe before the show, so you're in the hot seat. You ready to go?
I'm ready to go.
All right. Now, summer is in full swing in Michigan. What is your favorite thing to do around the state during the warmest months of the year?
Boy, visiting Lake Michigan and swimming in those Caribbean blue waters, albeit it's a little cold sometimes, but it doesn't get better than those white sand beaches on Lake Michigan.
Outstanding. So this actually leads perfectly into the next question. June is National Great Outdoors Month. What is the coolest outdoor adventure you've ever been on, or what do you really love doing outdoors?
Oh boy, family trip to Alaska was definitely the best. We walked in some meadows with some wild grizzly bears, which was terrifying, but beautiful, and really witness to the power of nature.
That sounds incredible, but yes, it also sounds terrifying. Who would you say has had the biggest impact on your career here at Michigan Medicine?
I would say my 2 mentors, Mike Inglesby and Chris Sonaday. Chris is the head of the transplant center here at Michigan. Has really influenced me in the operating room and taught me a lot of the things I know. Mike Inglesby has been my research mentor and really just a supporter of my career in general. Those 2 have been integral to my growth here at Michigan.
Nice. All right. Now, if you weren't a doctor, what do you think would be sort of another dream job that you would want?
Well, I think I'd be a musician for sure. I maybe athlete, but I do think a musician. I always love Elton John, so I guess sitting at a piano, singing some music would be awesome.
Do you play sort of in your free time?
No, I don't play. But
I don't know if I have any talent, but I want to be a musician.
That's exactly right. So
that's awesome. Well, thank you so much, Dr. Waits and Dr. Shingina, again, for joining us today and sharing the important work that you do. Once again, if you want to learn more about the liver transplant program at Michigan Medicine, go to mmheadlines.org. That's mmheadlines.org. That's all we have for this week. Thank you again to our guests for joining us. And thanks, as always, to our listeners and viewers for everything you do for patients, families, and each other. We'll see you next time.